Hi, can you hear me? I cannot start my video. Can you give me an access, please?
Yes, yes, of course. Yep, here we are.
Okay.
Hello, Shrikant. Sorry for being late.
Oh, no, that's okay. I was wondering what's happening because you guys are usually on time.
Yeah, sorry. Okay, we will wait, I think, for Andrei Sergeyevich calling me. One moment, please.
Okay.
Sorry for Andrei Sergeyevich is running from operation room.
Oh, is he? Okay.
Yeah.
Okay. That's fine. So how is the situation in Ukraine now? Is it somewhat better or no? Still the same?
I think almost the same, but Kyiv is still silent without any bombings and something like that. We have a difficult situation on the east or on the west of Ukraine. And that's why
I know
difficult
it's a
situation.
Difficult timings for you guys. Yeah.
We hope for the best.
Yeah. So is there any signs of it ending soon or no idea?
I have no idea.
Oh, that's
unfortunately.
Bad. Yeah.
We will hope for our military for the whole world.
I know. Yeah. I mean, all the world people are just trying to end the war, but it's definitely in Putin's hands. So I don't know why he's taking so long to put a closure to that.
Yeah. Okay. I think we can start our webinar.
Okay.
If you would not mind, yeah.
Yeah. Oh, not at all. So I see we only have 5 participants right now.
Yes, I see it. I don't know why.
Okay.
Maybe I will resend the invitation for this webinar.
Yeah, I think that will be good. So, I don't know whether people had logged in and then since they couldn't get on because of some reason, they probably thought that it's not happening anymore. Yeah.
Okay.
So shall I share my screen now?
Yes.
Okay.
Okay, go on. I mute myself.
Okay. So let's see. Okay, so good afternoon or good evening in Ukraine. And today's topic is therapy consideration in neurotransfers. So to give you an overview of today's session, I'm going to discuss the purpose of neurotransfers. We'll look at pre and post-operative management of nerve injuries, and then specific situations where the nerves are transferred. We'll look at the physiology of muscle re-innervation briefly, and then focus on some common transfers that we would see in our clinical setting, and then focus on discussing about general treatment consideration for retraining of these muscles or rewired muscles. So clinically, we see a number of situations where the nerves are traumatized. There may be either a traction injury or complete transection. And there are various situations where the nerves are likely to be damaged so badly that nerve graft or cable graft may not be an appropriate surgical option for these individuals. And in such situations, patients are considered for transferring the nerves in order for these patients to have function back again in their extremity. So historically, we have been treating these injuries. And if you look at the brachial plexus injury treatment, back when about 30, 40 years ago, we used to, following an injury, used to provide these patients with some kind of a splint or a brace or a sling so that we could position the extremity in order to reduce traction on the brachial plexus or in order to reduce traction on the injured nerves. Back then, of course, if the nerves are repairable, then the nerves were repaired, but otherwise, the therapists were required to maintain passive range of motion with the hopes that the nerves will recover and muscles will start to function again. And if patients had significant amount of pain following trauma, then the therapists were responsible for managing pain besides surgeon using some oral medications for pain control. And then as the muscles recovered following re-innervation of these muscles, then we started re-educating these muscles. But for a good chunk of time, it was like a wait and see as to what happens after an injury. And then only we'll start working on retraining these muscles back again. So nerve transfers is a procedure that is becoming a lot more favorable these days because of evidence that upon having transferred nerves, the muscles will start to function again. So let's look at the indication for nerve transfers. We know that if there is a defined nerve injury that is far proximal, then the distal muscle, it innervates. In that situation, even though the nerve may regenerate an inch a month or a millimeter a day, by the time the axons reach the target muscle, it will probably be too late, and then the motor end plates are likely to die. And then in such situations, there is a less possibility of muscles re-innervating again. So other indication is taking nerves that have a less important roles. For example, anterior interosseous nerve is usually, it supplies your pronator quadratus, and that can be spared for ulnar nerve reconstruction. Or there are some other nerves, other muscles which have dual or triple or maybe quadruple innervation, and one of that nerve can be rerouted to provide the function for the lost muscle. And then branches of a nerve that perform redundant function to other nerves, and that's, I previously described that as well. So transferring these nerves is basically to restore function if a crucial nerve is badly damaged. And this is mainly considered in a way that the recovery distance is shortened significantly by bringing a nerve very close to the motor end plate. So factors that affect nerve recovery, we know that age is a major factor. However, if a person is older, then it's not necessary that you may consider that the person is not suitable for nerve transfers, so to speak. So any age group can be considered suitable candidate for nerve transfer. It's important for us to look at the mechanism of injury, whether there was a compression of the nerve, traction of the nerve, or complete transection of the nerve. We obviously know that if there is a delay in treatment, then the nerve recovery is questionable. And it has been, the studies have been shown that if the nerve gaps are greater than 6 centimeters, the nerve recovery is again in question. And then, of course, we can add on to the surgical techniques and then misalignment or the distance from injury to muscle in terms of motor recovery. So timing is a crucial factor. So sooner these nerves are taken care of, then the better the response or better the recovery is. So studies have shown that if the nerve is transferred within 6 months to a year's period of time, there's a good possibility of muscle recovery and therefore good function. And if the nerve gaps are greater than 6 centimeters, obviously nerve transfers is a suitable option. However, we still should consider misdirection because the nerves have plexus in between the nerves, and it's quite likely that the muscle that they supply may not be targeted equally even after the transference of the nerve. So where the nerves are transferred, basically to provide person with the shoulder function, elbow, wrist, hand function, and in some situations, if sensation is necessary, then sensory nerve transfers can be also performed. So common nerve transfers for upper extremity includes transferring spinal accessory nerves to suprascapular nerve, taking off the radial nerve and transferring it to axillary nerve, intercostal nerves to musculocutaneous nerve, and a branch of flexor carpi ulnar is connecting to musculocutaneous nerve, and flexor carpi radialis, flexor deuterum superficialis, palmaris longus. These branches can be transferred to posterior introitious nerve or extensor carpi radialis brevis. So you can see that practically the whole entire upper extremity can be taken care of from transferring nerves successfully to provide the function, to regain shoulder function, to regain elbow function, wrist extension, forearm rotation, finger flexion, and so on. So preoperatively, therapists play a major role in terms of maximizing patients' passive mobility. That's a prerequisite. One must keep in mind that if patient has joint stiffness, the joints are stiffer, and even though nerve transfers is performed, despite of nerve showing good recovery, because the muscles, the joints are stiffer, the muscles will have a reduced function, and the muscles, recovering muscles, will not be able to provide adequate amount of mobility or desired mobility for the transfers. So it's very important for us, the therapist, to reduce joint and muscle contractures. It's essential for us to strengthen those muscles which are going to sacrifice their nerve. It is quite likely that there may be some depletion of muscle strength that is sparing one of the nerves for other functions. But many a times we have seen that when you have a nerve palsy, patients often go on to having substitution pattern, and they may have an overaction of functioning muscle. So in those situations, of course, we have to ensure that there is no substitution pattern or compensatory motion that these patients are performing, because ultimately, if they are doing compensatory motion, then the compensatory motion that they have had an established pattern of motion, then that is very difficult to break the pattern and then get them moving the targeted muscles again. So many a times the therapist may need to fabricate corrective splinting in order to maximize the passive joint mobility and reduce joint or muscle contraction. And in order for us to train these muscles that are going to spare their nerve fibers for other function, then it's essential for us to use EMG biofeedback technique, so that upon transferring these nerves are doing some different type of a function. So therefore, it's essential for us to consider the donor targeted action using EMG biofeedback. So prerequisite, therefore, is to maximize passive joint mobility. So now let's look at nerve transfers procedure. For example, this is your muscle fibers. You have an actin and myosin filament. This is your motor end plate. So you can imagine if the ulnar nerve is transected in axilla, by the time, and then even if the ulnar nerve is repaired in axilla, by the time the nerves regenerate to the motor end plate, it will be too far away because of the significant amount of distance. So the principle is to bring a nerve transfer closer to the motor end plate in order to shorten the distance of recovery and have the muscles functioning relatively quickly or relatively early following nerve transfers. So it's important for the therapist to understand the nerve healing process. So following nerve transection or nerve injury, the distal segment undergoes Wallerian degeneration. And then macrophages proliferation will cause relining of the neuronal tube distally, and gradually over time, the Schwann cells will have a remyelination process going on, as you can see right here. And then finally, the axons will start to regenerate, And as the axons regenerate and reach the target muscle, the muscles are starting to become alive again. So this is something the therapist must understand so that they can plan their muscle re-innervation training program following nerve transfers. So muscle re-innervation will happen as the nerves regenerate. We can very well see diagrammatically that some nascent units are starting to become alive. And as a result of these connection between the nerves or axons connecting to the motor end plate, the muscle starts to re-innervate. So therefore, it is important for the therapist or even the physiatrist to monitor the signs of re-innervation of these nerves. And then initially, as the nerves are starting to recover, as you can see right here, there are some units which are firing, but ultimately when it starts to recover, you can start having more nascent unit sort of giving you an information that muscle is starting to become alive again. So initially when the muscle is functioning at a very low level, then the motor function is initially undetectable through a naked eye. And we know that as the muscles recover, they recover from grade 1 to grade 5. Grade 1 is traces. Grade 2 is gravity eliminated motion of the muscle. Grade 3 is with or against gravity. Grade 4 with some resistance, and grade 5 is a maximum muscle strength against resistance. So it's very important for us to see how the muscles are starting to recover. And as the muscles are showing some recovery in therapy, we can start initiating EMG biofeedback unit. So as the muscle re-innervation starts to occur, there is a cholinergic synapse that are formed at the neuromuscular junction that produces acetylcholine. And initially, there is a decreased contractile ability of the muscles. So muscles are functioning at a very low level. But with the help of EMG biofeedback, we start re-educating these muscles using surface electrodes. And as we are retraining these muscles on an ongoing basis using EMG biofeedback unit, then there is a restoration of blood supply and motor function starts to improve gradually. So this is a patient who had a nerve transfers for posterior introitious nerve. And then here she is working using an EMG biofeedback unit. And the EMG biofeedback prompts her to perform motion of her wrist in accordance with the function. So let's see here.
Rest. Work. Rest.
So the unit gives her information when to work and when to rest. And this is all programmed in a way that we don't want these recovering muscles to become overly fatigued, because if they become overly fatigued, then the muscle recovery time is way too longer. So our therapy program is designed in a way that we ask a person to perform muscular action, hold for about 2 to 5 seconds, and then rest for 10 seconds, and then fire again, fire on the muscle again for 2 to 5 seconds and rest for 10 seconds again. And then we ask these patients to start off with 10 repetitions and then recommend that they perform 10 repetitions 3 or 4 times a day in order for the muscles to have enough amount of recovery and enough amount of muscular action. So gradually over time, we know that there'll be a collateral proliferation of these nerve endings or axons ending into the muscle fibers, and muscle will start to become alive over. So looking at the management of nerve transfers from hand therapy point of view, we'll continuously monitor their muscle recovery and then go on to training these muscles. So we have divided our therapy program into 4 different phases. So phase 1, following surgery, will provide these patients with the protective devices. So patients' positioning is very important so that there is no additional traction or traction where the nerves are repaired. Patients may require Resting hand splint, patients will perform, or patients will require anti-deformity splinting. However, they must maintain passive range of motion of their fingers or involved joints so that the joints do not become stiffer over time. And then as the muscles recover, then the retraining of the muscle becomes a lot more easier over time. And then we continuously will monitor their recovery. However, we keep a close communication with the physiatrist as well as hand surgeons who will instruct us in terms of how the muscle recovery is taking place. And then once we have obtained that information from the physiatrist who does nerve conduction studies, and then of course, when we get information from hand surgeons, then we'll use an EMG biofeedback unit as the muscles start to show signs of re-innervation. So it's very important for us to start training these muscles even though they are functioning at a very low level. So because the muscle recovery often goes unnoticed, patients are not aware of how much recovery is taking place in their muscles, and using the EMG biofeedback, which gives them an auditory signal as well as visual signals, the relearning is a lot more established, and this helps in cortical retraining of these recovering muscles. So early motion for cortical retraining is enhanced by using EMG biofeedback. And then as the muscle becomes stronger, for example, going from grade 1 muscle strength from grade 1, as it starts to improve to grade 2, at that stage, we'll still continue using EMG biofeedback, but at that stage, we may consider providing these patients with a dynamic assist splinting or dynamic assist orthosis. In some situations, if the patients still have difficulty in identifying the patterns of motion, we may consider using mirror box therapy. So why do we use EMG biofeedback in our clinical setting in hand therapy? Is because we want to monitor the skeletal muscular activity as these muscles start to re-innervate. And then this EMG biofeedback basically gives us an electrical impulse from peripheral nerves using that EMG device. And then it helps on focusing, regaining motor control in that injured extremity. And because it provides visual and auditory feedback through the signals, this helps in enhancing motor learning or retraining these muscles as the muscles starts to function more and more again. So overall, the EMG biofeedback device is much more useful so that we can enhance awareness of the skeletal muscle recovery. And then we have seen that this has given us superior outcome. So this is a patient who had nerve transfers, especially for a reconstruction of shoulder. So he had a spinal accessory nerve connected to the suprascapular nerve. He also had nerve transfers from the elbow joint from the flexor muscles, median nerve to musculocutaneous nerve. So here he's showing his ability in gravity, against gravity from 40 degrees onwards. But we identified that even though he had limited muscular activity, we wanted to enhance that muscular function by providing the patient with a dynamic assistance. It's very important for the therapist to understand the biomechanics of joint motion. If this person keeps his extremity or elbow joint fully extended, the muscles have to generate adequate amount of force to convert joint compression into a rotatory torque. And the muscles definitely do not have that much of capacity to convert the joint compression or joint approximation to a rotatory torque. So therefore, in these situations, we have to provide these patients with a dynamic assistance. So this we fabricate in hand therapy, and then we have provided these patients with multiple rubber bands, and this has given him better and better control over time. And then the patients continue using this device along with EMG biofeedback in order for them to regain the strength and regain the mobility of the elbow joint. And then here, of course, we allow these patients to use their extremity for different types of functional activities, such as basic ideal like drinking coffee or holding on to the tool and so on. So this minimizes excessive work of flexion. These rubber bands definitely aids in providing them with muscle action and muscle function. And then we have identified that by using a dynamic assist splinting, the muscles have less tendency to become fatigued very quickly. So we have used that significantly, and you'll see that throughout my presentation as well. So as these patients are using their extremity or using their dynamic assist splinting, we still use the EMG biofeedback on a gradual basis and then train these muscles to work against gravity. And at that stage, when the muscles have an ability to work against gravity, at that stage, we'll program the unit, the EMG unit, so that the patients have EMG triggered electrical stimulation. With providing them with the electrical stimulation, we continuously go on strengthening the muscles so that we have a desired function as well over time. So here there are a few dynamic assist splinting, but here we are using EMG triggered electrical stimulation. So the unit is programmable in such a way that they reach a specific threshold, and the moment the person reaches a specific threshold, the unit starts to electrically stimulate muscles in order to strengthen those muscles over time. So this is another patient who had the nerve transfers as well. So this patient had ulnar nerve transfer.
Try doing it now.
Yeah. So here, of course,
go ahead. Yes, go ahead, sir. So squeeze heavily there and go up.
So this patient had Oberlin transfer. So here we have given the person to grab onto an object, and attempt flexion of the wrist joint, and then use the electrical stim to regain muscular function. So this is a dynamic assessment for another individual who had post-intraosseous nerve reconstruction.
Now try lifting.
So we start off with low threshold, allow these patients to have few trials.
Okay, so go ahead and
so this is the screen that these patients have to look at, reaching that particular threshold, and then the electrical stimulation kicks in and it helps in strengthening.
When it says rest, get it down to zero completely. I think
yeah, so that's fine. We should stop.
Rest.
So the visual and auditory feedback is definitely very helpful because patients know how their muscles are recovering. So this becomes a reinforcer for them, because we very well know that following an injury and upon having nerve transfers, it's a lengthy rehab. And sometimes the patients may get discouraged if they're not noticing as to how much their muscles are starting to function or how much their muscles are starting to recover. So these units, these programmable units are definitely helpful in increasing their muscle strength, increasing their muscle capacity, helps in increasing their muscle endurance. But at the same time, because of the visual and auditory feedback they are getting continuously by using these devices, patients are very much motivated in participating with the rehabilitation program. So, and then phase 4 involves with the strengthening of the muscles. For this patient had AIN transfers for deep branch of ulnar nerve using electrical stimulation and then strengthening of the muscles. And same way here, the person has nerve transfers for wrist extensors. He's performing wrist extension using EMG triggered electrical stimulation as well. So let's look at few cases and we can very well understand how the whole entire nerve transfer are dealt with in hand therapy program. So this fellow is 45-year-old right-hand dominant individual. He noticed that he has a progressive weakness of his right shoulder abduction and flexion, he had a progressive weakness of right shoulder abduction and flexion. And he also noticed that he is having progressive weakness of his elbow flexor as well. On examination, we identified that he had a wasting of his deltoid, the biceps infrasupraspinatus were were atrophied significantly as a result of denervation. In terms of their strength, deltoid has 0 strength, biceps at 1, brachialis at 2, infraspinatus range somewhere between 1 to 2, triceps at 4 strength. So looking at his x-rays and all the details, detailed medical history, it was identified that the patient had cervical spondylotic amyotrophy affecting C5 and C6 nerve roots. So here, this is his pre-op status. As you can see that he's having extreme difficulty bending his, moving his shoulder or bending his elbow. His forearm is moving okay. He had difficulty supinating his forearm because of lack of his elbow flexion. However, he had a good hand function, good wrist function. This is his video from the posterior side. You can see that he is unable to lift his shoulder. He is unable to move his elbow and is quite devastated, getting frustrated because of his inability to move the extremity. So, excuse me, from the surgical point of view, he had flexor digitum superficialis fascicle of the median nerve transferred to biceps, which was connected to the musculocutaneous nerve. He also had radial branch of lateral and long triceps had transferred to axillary nerve, and then branch of anterior part of deltoid was connected through nerve transfers. So the nerve transfers included diagrammatically the branches to lateral and long triceps were connected to axillary nerve and then to the anterior part of deltoid so that he could have greater function. So superficialis fascicle of the median nerve was connected to the biceps branch of musculocutaneous nerve so that he had good amount of elbow flexion. So looking at the location where the nerves were transferred, we started using EMG biofeedback. So 2 months post-operatively, we identified that he had a flicker muscle recovery noticed on surface EMG electrodes. This was confirmed by the physiatrist as well, who showed us that his muscles are starting to recover. So we use surface electrodes for muscle re-education. Our parameters of using EMG biofeedback consisted of high sensitivity and lower threshold. So that means that the slightest amount of muscular activity was picked up by these electrodes and displayed on the monitor. And then we kept the lowest threshold so that he could reach that target relatively easily. And then we allowed the person to perform 3 to 5 muscle contraction, hold the muscle contraction, sustain muscle contraction, somewhere between 2 to 5 seconds. And then we allowed the 10-second to 15-second rest period. And we only encouraged him to perform 5 repetitions and then gradually increase these repetitions as the patient improved over time. And then as the patient improved in terms of his muscular control, then we adjusted the parameters by decreasing the sensitivity and increasing the threshold. So he started showing great recovery. And then when we noticed that the muscle is starting to have a greater muscular contraction on our EMG biofeedback machine, then we used gravity eliminated motion by suspending his arm and then using using EMG biofeedback for muscle re-education as well. So here the patient is showing moving his elbow flexion, and of course his arm is suspended in a sling. He also performed shoulder abduction, shoulder adduction as well in order to train the shoulder muscles as well. So 3 months post-operatively, we identified that he had an adequate strength. However, the patient had difficulty flexing his elbow from fully extended position. So on examination, biomechanically on examination, we identified that he had a better ability to flex his elbow from 60 degrees onwards with minimal effort. And then therefore at that stage, we considered fabrication of this dynamic assist splinting, which helped in retraining these muscles And gradually over time, that helped in enhancing muscular activity so that he could use this device effectively for basic ADL, retraining of the muscle, strengthening of the muscles, and so on. And then gradually, as the person started increasing muscle control, and when we noticed that he's capable of moving his arm against gravity at 5 months post-operatively, we started reducing the rubber bands, and then ultimately at 5 months, we reduced quite a number of rubber bands, and he no longer required any additional rubber bands here to flex his elbow. However, we still needed to block his elbow at certain degrees of extension, as you can see right here. So we had to block the elbow at about 30 degrees. Here you can see that he has a minimal effort required for him to flex his elbow. And of course, this is his shoulder retraining. So no rubber bands, if you notice that here. And then 5 months post-operatively, we used EMG-triggered electrical stimulation, and then carried on with the strengthening program along with that. So the reason we are using brace here because we found out that patient muscles were getting easily fatigued, and the brace definitely minimized fatiguing muscles. And then 5 months post-operatively, at the end of 5 or closer to 6 months, he no longer required the brace. However, we emphasize that he still continues to use the brace, especially when he notices that his muscles are getting tired. So 6 months post-operatively, we can see that he's not using brace as much. There's a good elbow flexion. And then, of course, he has good internal and external rotation. As you can see, external rotation was somewhat limited because of his previous limitation to begin with. But here, of course, he has a full elevation of his arm, forward flexion, full elbow extension and flexion. And then he decided to return to work despite of us telling him not to at this point. So he couldn't stay off work because he was not on workman's comp. He was not having any income because being off work. So here, of course, he works in a foundry machine. He's still using his brace because he identified that if he didn't use the brace, he had difficulty maintaining elbow flexion for lengthier periods of time. So that was his choice, and he mentioned to us that using a brace minimizes his muscles from getting too fatigued. So here, of course, he's fixing. He just recently fixed the electrical sort of lamp or light in his house. And here he is repairing his car, doing the sanding of his car, as you can see right there. At 9 months post-operatively, and 1 year post-operatively, he's back playing golf. But his preference was to still continue using brace until he had gained enough good strength. So now, of course, it's about 2 years post-op. He no longer requires any kind of a brace and is functioning normally again. So let's look at additional illustrative cases. This is a 30-year-old farmer. He had a snowmobile accident. His right hand dominant. He had a fracture of the proximal humerus. He ended up having right brachial plexus palsy. On physical examination, patient had suprainfraspinatus deltoid biceps. Wrist and finger extensors were 0 out of 5. However, he had a finger wrist flexors, finger and wrist flexors, abductor pollicis brevis were grade 5. So these are his x-rays following an injury. He required immediately in an emergency after about 3 to 4 days, he was considered suitable candidate. Once he was stabilized medically, he required open reduction and entel fixation. So his MRI showed that he had a brachial plexus injury, as you can see right here. He had a C5, C6, and C7 involvement. So on EMG finding, he had a complete denervation of supraspinatus, deltoid biceps, infraspinatus as well, and of course, finger flexors. So the recommended treatment that he had was his upper trunk was explored. He required distal spinal accessory nerve transfers to suprascapular nerve. He also had a double nerve transfers for elbow flexion, and it has been proven that it's very effective in terms of regaining the muscle strength, and the muscles can be easily trainable. So the expandable fascicles from median and ulnar nerves were taken and transferred to brachialis as well as biceps motor branches. So brachial plexus surgery involved exploration of right brachial plexus. He obviously required neurolysis of his upper trunk. He had a nerve graft from C6 to anterior division of upper trunk. He had nerve transfers from ulnar nerve to musculocutaneous, and median nerve to musculocutaneous as well. And then he had a reconstruction of axillary nerve by transferring medial pectoral to axillary nerve. So here he is a surgical incision as in his upper extremity. However, the patient was not very compliant initially because he did not notice much of a recovery in terms of his nerve function. So his nerve transfer surgery was in April 2006. And here, of course, the musculocutaneous nerve was connected to the nerves. And then, of course, we started training him with EMG biofeedback, and he's performing gravity eliminated motion of his shoulder, gravity eliminated motion of his elbow joint. So here in this situation, of course, we had to not only provide him with the elbow dynamic assist splinting, but because he had a reconstruction of the extensor nerves as well, we had to provide him with the dynamic assist splinting for his fingers and the wrist, so that we could retrain recovering extensors of the wrist and extensors of fingers. And here, of course, we are using EMG biofeedback unit as well. So 5 months post-operatively, you can see that he's no longer requiring any rubber bands as compared to the previous video. You can see he had multiple rubber bands here, but 5 months he did not require any rubber bands. We still had to maintain his elbow blocked in about 40 degrees less than full extension. He continued moving his elbow and then using EMG biofeedback. We identified that 18 months later, he still did not regain good extension, good strength in his muscles for wrist extensors or finger extensors. And therefore, he was considered a suitable candidate for wrist fusion and then transference of flexor carpi radialis to extensor deterrum communis, flexor tendon from superficialis. Flexor tendon superficialis from ring was taken and was transferred to EPL. So he had a tendon transfer here. So from the muscle recovery point of view, you can see that his wrist extensors did not improve. His finger extensors and thumb extensors did not improve. However, he had good intrinsic function. So here he's undergoing tendon transfers procedure as described. Superficialis was taken off and then connected to EPL. And this is the procedure, as you can see. And then, of course, he required wrist fusion in order for us to stabilize the wrist in a functional position so that we could work on retraining his wrist and thumb extensor. So results 2 years post-operatively, he had a fairly good shoulder function. And I wish that he would have been compliant to start off with, so that we could have regained his shoulder function much better. Here is showing his shoulder motion.
And down, bend.
And then 2 years post-operatively, he returned back to He returned back to farming. He's using a farming equipment, as you can see right here. So let's say the case number 3, this lady had a Parsonage-Turner syndrome. And we know that the Parsonage-Turner syndrome is an acute brachial neuropathy. The etiology is idiopathic in nature. Most often, or 97% of these patients have suprascapular nerve involvement. Initially, patients start off with severe shoulder pain, and that continues over time. And the whole entire upper extremity becomes severely weaker, and it is reported that the recovery may be questionable. So this is a 68-year-old female. The reason I included her, that just to show you that the age is no bar for having patients go through the nerve transfer. So she had C6 to some C7 involvement. Her symptoms were lasting for almost a year or more than a year's period of time. And therefore, she was considered to be an emergency nerve transfers candidate. Her diagnosis was not pre-established. When she came to the peripheral nerve clinic, it was identified that she had limited time in terms of having nerve transfers. So fascicles from median nerve, from FCR and from pronator was connected to the brachialis muscle. The fascicles were taken from ulnar nerve and from flexor carpinalis and flexor determinus profundus to biceps. And then she was referred to hand therapy at 4.5 months following the procedure. So we performed post-operative assessment. We started her on EMG biofeedback muscle re-education program. She, similar to other cases, she also required dynamic splinting. We started strengthening of the muscles that have sacrificed their nerves because they require strengthening as well in order for us to have an adequate and appropriate amount of function. And then overall in therapy, besides having EMG biofeedback, EMG triggered electrical stimulation, she also required generalized strengthening of her entire upper extremity as she progressed clinically. So here on physical examination, we identified that she had limited elbow flexion. She couldn't flex her elbow from an extended position. However, we identified in a situation that she could have better elbow control when the elbow joint was placed at 90 degrees or 90 plus degrees of flexion. So here, of course, you can see that she is having quite a bit of limitation in terms of flexion. So we provided her with dynamic splinting. As you can see that she's bending relatively better. So this is what she required. And of course, continuation of using EMG biofeedback, EMG triggered electrical stimulation, as well as dynamic splinting provided her with a greater arc of motion. So this is her status. This is her status. Let's go further. This is her status. 2 years post-operatively, she has great shoulder motion, as you can see right here. She has no complaints of pain. She's lifting 5-pound weight here, having good strength in her elbow flexion. And here, of course, she is using 10-pound weight, performing rotation of the forearm with elbow in varying degrees of flexion and extension. And here she is showing off her elbow flexion. So this is case number 4, who had a complex upper extremity fracture. This fellow is a 25-year-old male. He had a snowmobile accident. He had a severe comminuted fracture of the humeral head and shaft. You can see that he has a fracture proximally as well as centrally, and his scapula was also fragmented. And patient suffered an infraclavicular brachial plexus injury. So this is his scapular fracture, the multiple fracture. Patients required, once he was stable medically, he required open reduction and interfixation of his humeral head as well as humeral shaft. So He was then sent for shoulder rehab. We identified that he had a weak upper extremity. At 6 months following open reduction and into fixation, he required nerve transfers and then also the tendon transfers. And then he was re-referred for retraining in hand therapy. So here he is, you can see that he is having quite a bit of difficulty flexing his elbow. His shoulder range of motion was also quite limited and therefore required shoulder mobilization, EMG biofeedback, and electrical stimulation for strengthening. And this is, of course, at a later stage when he had a relatively better control on his finger motion. So this is 2.5 years post-operatively. You can see that he has good elbow strength. He has a good forearm strength. Here he is showing his range of motion. Oh, I don't know why that is not working, but I hope this is his elbow flexion, elbow extension, and good hand function. No, I have to reprogram this. So what is the highlight of my presentation today? It is that we extensively use EMG biofeedback and EMG triggered electrical stimulation as these muscles start to re-innervate. And in addition to that, we use dynamic splinting along with EMG biofeedback and triggered stimulation to regain elbow motion and strength. And as well as with other cases, we also use dynamic splinting to regain wrist range of motion and finger range of motion, as I showed you with the different cases in my series. So combination of EMG triggered electrical stimulation, dynamic splinting definitely gives us a better control, better strength, and better functional return of these patients. So again, I'm repeating this again. So the purpose of using EMG biofeedback is to monitor skeletal muscular activity as the muscles start to re-innervate. This device helps us to detect electrical impulses from peripheral nerves. And of course, we use EMG device and electric surface electrodes. It helps on focusing, regaining of muscle control. It also helps the patient in regaining or retraining the muscle motor control following their injury, following their nerve transfers, because it continuously gives patients their visual as well as auditory feedback, and that helps in restoring cortical awareness of return of muscle function. So in conclusion, we know that brachial plexopathy is no longer wait and see management. Because of advancement of Neurotransfers Procedure, we can very well see that we can have very good predictable results. And then I've shown you successful surgical outcome. And this is, of course, dependent upon knowing nerve response to injury and how these nerves heal. And we must understand how the muscle re-innervation takes place so that we can use this knowledge and use various techniques that I've given or described here in order for us to have a well-structured program to restore and regain function in injured nerve or injured extremity. So I would like to specifically thank Dr. Doug Ross, one of our peripheral nerve surgeon, Dr. Chris Doherty, he's also our peripheral nerve surgeon, and Dr. Tom Miller, who is our physiatrist who does the nerve conduction studies in the EMG labs and so on. Thank you. And I'll be delighted to answer your questions.
Thank you very much. Hi, Shrikant. Sorry, we have some bad luck with this webinar because we postponed it 2 or maybe 3 times, and now I'm late because I was in the OR. So we have something.
Oh, that's okay. So sorry, I had to change that, previously.
But that's okay. Very interesting lecture as always. Thank you very much. For now, we don't have any questions, not in the chat, not in the Q&A box, but I have a question.
Okay.
For you, you use electrical stimulation for the rehabilitation. When you start using electrical stimulation? Immediately after the operation, or when we first can confirm the re-innervation by EMG? study?
So I normally start electrical stimulation once we know that the muscles have recovered somewhat. And on EMG biofeedback, if the patients are able to sustain muscle contraction 80%, 60 to 80% of the time on the given prescribed program, and they should have at least grade 2 or slightly above grade 2, maybe grade 3 muscle strength before I start using electrical stimulation.
I see. Thank you very much. And what do you think? How electrical stimulation can affect terminal sprouting when the axon tried to re-innervate the neighbor muscle fibers?
Right. I mean, there is still a controversy whether electrical stimulation does any harm to regenerating axons or whether it is helpful. But there are some studies which show that if you are stimulating at 20 megahertz, because the muscles are different types that are quickly adapting or quickly acting or fast acting muscle fibers or slowly acting muscle fibers. So the difference of the muscle group is, for example, sprinter, those who do 100 meters run in a short period of time, they have they have a different type of muscle fibers as compared to the people who run a marathon. They have a different type of muscle fiber, right? So some studies show that if you stimulate the muscles at 20 to 30 megahertz, then it helps converting the muscle into a specific fast twitch fiber or low twitch fiber. So there are some other studies which show that earlier stimulation of these nerves before the muscle starts to re-innervate may have an effect on sprouting of these axons to the adjacent areas. My preference is to use the nerve stimulation after they have gained 2 plus or 2 plus or 3 muscle strength. So there is a lesser of a danger of not having these muscles re-innervate. But when the nerve starts to regenerate, the collateral axons are now sprouting and connecting to the other areas which are not previously connected. So in those situations, the sprouting definitely becomes much more advanced, and as you provide muscle contraction, that the muscles will have a greater and greater amount of blood supply, so the muscles will have greater oxygen supply as well as greater amount of blood supply for the muscles to recover and regain strength as well.
I see. Thank you very much. I also recommend swimming or pool for all of my brachial plexus and nerve injuries. So what do you think about some maybe exercises in water? Because water can some kind
so the buoyancy of the water, because
yes.
You become somewhat weightless. You can have very very weak muscle working very well when you are moving these muscles in terms of buoyancy. So yes, aquatic therapy program is definitely beneficial. If you have that facility available to your patient, then it's great. We at our facility used to have a pool for brachial plexus injuries, but because of the budgetary restraints and COVID, that pool program was completely stopped, and I don't know when it will improve again. But we have recommended patients to go to for example, YMCA or YWCA or community pool, at specific time when the community pools are not overly crowded. So they should select a time frame and then, discuss that with these providers where they have a pool so that they can go in specific time, because we don't want people bumping into them and having, say, traction injury or injury of that kind. So pool therapy is definitely beneficial for these patients to have fast recovery as well.
Okay, thank you. And one more question from me is about nerve gliding exercises.
Right.
When do you recommend to start? nerve gliding exercises, and in what cases, maybe in injury or in compression neuropathies too.
Okay, so we'll divide these patients into 3 different groups, for example. If the patients are having nerve transfers, the nerve transfers are seldom or never, the nerves are never, the connection is never under any tension. So in those situations, it's important for you to start doing nerve gliding, but assisted, because they don't have muscle function. So the assisted nerve gliding can be performed by the patient with the assistance of their spouses or the therapist. So we have to specifically, walk them through as to what the nerve gliding exercises are. If they have a compressive neuropathy as a result of, for example, cubital tunnel, for example, where the nerve often gets compressed. So in that situation, my battery is becoming low, so I'm going to connect this here.
Okay.
So nerve gliding, especially if the patients have cubital tunnel or they may have acute tension nerve, as you see, UETT, upper extremity nerve tension test. So for example, somebody is a postural having a deformity, then in that situation, then extending their neck, extending their back, and moving their shoulder and arm in abduction will definitely put a traction on their nerves. In such situations, these patients may have some symptoms as a result of their posture. So these patients may begin with some nerve gliding in early stages. So nerve gliding doesn't mean that they should be able to go through the whole entire arc of motion. They should be able to, say, go to a certain point and then perform nerve gliding up to a point where they don't notice any recurring symptoms. And then gradually you can increase mobilization of these nerves. So this mobilization, it can be done by the therapist in order to maximize the gliding of the nerve. So there are specific nerve gliding exercises that can be performed by the patient, except they need a very well designated home program that they can carry out at home.
I see. And when do you start nerve gliding exercises after the surgery? When we don't have any traction on the suture side.
So after the surgery, maybe a week to 10 days after is much safer, because we don't want other areas to cause pain and discomfort, because patients will usually have, if they have pain and discomfort, the muscles may go in spasm and they may retard motion of that joint. So about 5 to 10 days post-operatively, depending on their symptoms of pain and discomfort.
I see. Thank you very much. I think we don't have any questions, not in the chat, not in the Q&A box. So thank you very much. I think we can wrap up. If it's okay, I will put the recording of this lecture to YouTube channel and send you the link, okay?
Okay. Yeah, and I sent you Dr. Faber's email address.
Okay.
Yeah, did you receive that?
I think, yes, I will check my, you send it to me today, yeah?
No, a few days ago. So I think last week. Dr. Faber is one of our surgeons who does lots of shoulder and elbow surgeries. So, I spoke to him and I said that, would you be interested? And he said, definitely. Yes.
Yeah. Of course, I will write him a letter, but just in these days, I have a lot of work in the OR, so I don't have time to manage all of this. I definitely will write him a letter, because yes, we are definitely are interested in some elbow and shoulder webinars. So.
Okay, good. Yeah. Thank you.
Thank you very much.
Most welcome. Thank you.
Thank you. So we'll be in touch.
Sure, yeah.
Okay, I think we can wrap up. Thank you very much. Sorry for my late, but that was a great lecture. I see it almost from the start. So thank you very much.
Yeah, thank you. Have a nice day.
Have a nice day. Отже, дякую, шановні колеги, що були з нами. Нагадаю, що в цей вівторок у нас о 8 вечора, 8:30 буде, як завжди, вебінар Fresh. І зараз навіть скажу, на яку тему. З приводу реконструкції м'яких тканин. Вот. Тому запрошую всіх, розсилочка буде обов'язково. Я думаю, що завтра зранку і, як завжди, в четвер зранку. Дякую всім, що були з нами. До побачення, до нових зустрічей. Ми обов'язково переможемо.